Dr. Sundar is going to talk to us right now on diabetes treatment from ancient times to present. And this is his entire journey that is going to take us from where we are today and where we started from related to diabetes treatment. I think he's already been introduced. So I'm not going to get into that. I think, Sundar, you can straight away share your screen and start the lecture. Thank you so much for stepping in.
Thank you so much for putting me on the spot, giving me peptic ulcer disease. And I hope people...
That's what friends are for. That's what friends are for.
And I hope everybody is not like, overdose of Dr. Mudalia and you get indigestion.
You're so passionate in speaking, so it's always a pleasure to hear you.
But
Okay,
Sundar,
me...
I think you did the right thing. You alone can do it. It's great.
Not in 15 minutes. I'll try.
Yeah.
And you'll make the best out of it. No worries.
Please start, Sundar.
Okay. Hang on. Just bear with me a little bit.
Yeah. Take your time.
I am sharing my screen, but this other thing keeps popping in there. Hang on. Okay, you can see my screen and my slides.
Yes,
right,
we can.
So thank you very much. And thank you, Sanjay. In case you didn't know it, Sanjay was my junior in high school in Mumbai.
Oh.
I don't want to say close to 50 years ago. So we are from the same high school in Mumbai. Thank you, Sanjay.
and that's why he could take the liberty.
Anyway, so I'm going to talk about a little bit different switch tracks, talk about diabetes treatment from ancient times to the present. So first of all, my conflict of interest disclosure. I do speak for AstraZeneca only in the Middle East, and I have research support from the NIH. So what am I going to do? I'm going to review the evolution of diabetes therapy over the centuries, how we used herbs, chemicals, starvation diets, till we came to insulin in 1923, almost 100 years ago. And then I'll tell you what a revolution it was after that, in all the drugs which we got. And some words about the FDA. Everybody calls it the mandate. It is not a mandate. When I wrote one of my papers, the reviewer said, go back and look at it. It is a guidance, but it's almost like they're twisting your hand. You better do it or you won't give it. But it's not a mandate. I'll talk about the CVOTs. And finally, what is the impact of the CVOT on our current guidelines? Just to refresh our memories. As you know, I used to start with this slide. The first description of diabetes, if you read all the Western textbook, is said to be from Arathias of Cappadocia, who was a Greek who lived in present-day Turkey. And he first, it is said, coined the term diabenin, which in Greek means a siphon, means the water just runs through you. At that time, they didn't know, diabetes insipidus, diabetes mellitus, and all that. Galen, who was about 100 years after him, also a Greek, and he said the kidney is the root of the problem over there. But if you really want the first history of diabetes, and I've looked at it, this is a stamp issued by Egypt in 1971. And so for those of you, I'm a big history buff. This stamp does not say Egypt. This says UAR 1971. In 1971, there was no Egypt. It was the United Arab Republic of Syria and Egypt. There was only one country. Then they split over there. Anyway, this depicts the physician Hisira, 3000 BC. He was the physician to the pharaoh Djoser in the third dynasty of the Old Kingdom. This is 1500 years before Tutankhamun. At that time, the Egyptians did not even know how to build pyramids. They used to build mastabas, and then they learned how to build it. And actually, I have been to where it is about 30 kilometers away from Egypt. If you go, you should go to Saqqara. That's where he's there. Anyway, he wrote something called the Ebers Papyrus, The Ebers papyrus, actually it's a misspelling here. Ebers was a German Egyptologist. He bought this in the bazaars in Luxor. And today, the original is still in the University of Leipzig. You can read it. And that is what it is there. But let me, another little historical point if you want. This is not hieroglyphics. This is hieroglyphics. You know, the pictures of all these birds and all. So what is this? So the Egyptians wrote in 3 languages: hieroglyphics, hieratic, and there's another script called demotic. That's how we figured it out, because the Rosetta Stone had both of them together. Anyway, what did he say over there? So this is from Eber's original translation. And he described a condition just like diabetes. And I showed this in my previous presentation. He said, if this condition like diabetes, you can use a rectal injection of olive oil, honey, sweet beer, salt, and seeds of the wonder fruit. You can anoint the phallus, or you can do this other thing, which is a mixture, and you know, all these things: fresh milk, beer, green dates. I've been in the Middle East. I ask people, what are green dates? Nobody's heard of it, but that's what the translation is. And he said, put it all and take it for 4 days, and your diabetes is over. Then, of course, around 300 AD, and I know I listened to Dr. Mohan has published a great book on diabetes before insulin and with insulin in India. And it's a JAPI article. I really refer it to it, how insulin was first used in India right after it was available, and how insulin was treated in Kolkata in the 1800s. But Charaka, as far as I can find out, lived about 300 AD in the time of the Emperor Kanishka. And he, of course, described the concept of prameha and madhumeha in the Charaka Samhita. Now, Shushruta probably lived 200 years before him, and there is historical evidence for this. And those of you who are interested in history, I'm fascinated by history. The problem with India's history is we depended on Smruti and Shruti. We never wrote anything down. And for those who are interested, Indian history today is dated on only one fact. We have all the Puranas, Vedas. What time is it? The only time which we can fix in history is 326 BC, when Alexander came and defeated Porus. The Greeks wrote everything down. And that's how we date everything. And the Charaka Samhita and all, these are there in the Buddhist manuscripts found in China. They date back to 100 BC and 100 AD actually over there. So anyway, just my passion for history as well over there. So this, I looked it up online, but it is there in the Prameha Chikitsa. And just look at what he describes. So he says people suffering from prameha are 2 kinds of people: those who are obese and strong, and those who are emaciated. So I think he is describing type 2 diabetes and type 1 diabetes. Remember, insulin sensitive, insulin resistant was only described in 1933 by Himsworth over there. But he's already saying, and he's saying, if you belong to this one, give them nourishing therapy. And those who are strong and have more doshas, they should be treated with elimination therapy. And he says, for that, he says, the oleated fat patient should be given various recipes, and they have to eliminate metabolic waste products through both the upward and downward tract. Very clear, I mean, there over there. And after that, you do a lot of things over there. What happened after that? Over the centuries, various herbs, diets, chemicals were used to treat diabetes. Until the 1700s, now is when we get better literature. This was in 1797. This is the original book. For those who can read the Roman numerals, that is 1797. John Rollo was a Surgeon General in the Royal Artillery. So this is 1700s. We're not even in the 1800s. Guess what? He published 2 cases of diabetes mellitus with remarks on their progress and the nature of the disease. What did he say then? And what he gave was the meat diet. Okay. After that, in the 1800s, the father of diabetology is actually a Frenchman called Apollinaire Bouchard. And that is him over there. What he did was he resurrected Rollo's treatment, but he's the first one to say individualized treatment for patients. And now we are coming to precision medicine. He said, don't take milk because of its carbohydrate content. And he urged that patients eat as little as possible and masticate carefully. He's the first one who introduced the intelligent use of exercise in the treatment of diabetes. And he advocated daily urine testing to guard against a return of sugar without the patient's knowledge. Think about this. First, checking of the sugar, because if, what you don't know cannot affect you. If our patients, even if they're well treated, I tell my patients, check your sugar at least twice a week, because slowly your diet will go bad and it will come back. And he prescribed also sodium bicarbonate, chalk, magnesia, citrate, tartrate, ammonium, potassium salts. All this is in a great book, and thanks to Google, they've digitized these books. This book was written in 1919. If you're really interested, Total Dietary Regulation in the Mind, gives you the whole history of treatment of diabetes. I think I saw Shilpa over there. This will be very interesting to you, Shilpa, and I would love to get your opinion on it. But if you want the original book, it's available on Amazon. Apollinaire Bouchard de la Glucosure. He wrote it in 1883. Let's come to the late 1800s. We're still in 1892. And Sir William Osler is considered the father of medicine in the US. He's a Canadian, actually, but this is his book, The Principles of Practice of Medicine. So 1892, what did he say? He recommended a dietary prescription of, look at this diet, 65% fat, 32% protein, and 3% carbohydrate. And he said, abstain from all fruits and all that garden stuff. He proposed to avoid worry and lead an even quiet life in an equitable climate. Use flannel or silk near the skin, take a cold bath daily and a Turkish bath occasionally, and get Turkish bath are the steam baths, and get moderate exercise or massage. But guess what more he said? He noted that no one drug has directly curative influence, but that opium alone stands the test of experience as a remedy capable of limiting the progress of the disease. So what primitive methods we had, but at that time it was standard of care. And then come to the 1900s. This is 10 years before insulin. Frederick Allen, and actually he was the mentor to Elliot Jocelyn. He proposed the oat cure. And he said, do not give any other carbohydrate because then you will get glucosuria. And he also said, no meat on oat days. Even eggs are sometimes harmful. And then he said, the oat and butter diet may cause diarrhea, which can again be checked by opium. And then, people can get edema, oat edema, diuretics such as thiosin can prevent the edema over there. Let's come to Elliot Jocelyn, 1916. See what he said. The treatment of diabetes mellitus, rather more success is achieved by surgeons in the treatment of general peritonitis than is attained by physicians in the treatment of diabetic coma. He said surgeons do a better job to treat peritonitis. This is in 1916. But he also said something fascinating. He said, whenever I'm asked to see a new case of diabetes, I tell the physician, don't change the diet or omit all the fat until the consultation takes place. Then when the patient comes for treatment, I first omit all the fat in the diet. After 2 days, the protein, and then half the carbohydrate, and then fast the patient. So now we come to the keto diets over there. 6 years later, of course, we got the discovery of insulin. This is one of the earliest vials. And this was made by the University of Toronto over there, and they could not keep up with the production. So in 1924, they sold the patent. Now, 4 people, as you know, were responsible: Banting, Best, MacLeod, and Collip. But MacLeod and Banting said, we don't want any patent on it. So the patent was in the name of Best and Collip, and they each sold their patent for $1 to the University of Toronto, and it was sold to Eli Lilly to do it. And you all know the price of insulin. After that, what happened is, after insulin came in 1923, we have had in the first 73 years, we only had NPH, Lente, Ultra Lente, insulin. Then 1942, sulfonylureas, biguanides in the 50s. And then next 18 years, a lot of drugs, metformin, TZDs, insulin, and of course, the latest drug so far, the SGLT2 inhibitors. And What do these drugs do? Well, we know diabetes is a complex disease. You've seen this slide many times before, Ralph DeFronzo. Defects in all the organs over there. But good news, we have drugs on all of these. What do they? And of course, we have insulin. All of these lower blood glucose levels. But the problem is that tight control of glucose, as we know, improves microvascular complications, but does nothing to CVD. In fact, in the ACCORD study, the NIH stopped the study early because there was more all-cause and cardiovascular mortality. I'm not joking. It's about a 20%. There I said, stop the study. And in the previous session, we discussed, very rarely are studies stopped. Usually they are stopped because of futility. And that was the look ahead study, which I was part of. The NIH came and said, no point doing it. This is a waste of money. Or for harm, like in this case, they said, stop the study. Or very rarely for benefit, like with the DAPA-CKD and the Credence Star, the DSMB said, stop the study. But anyway, tight glycemic control may be harmful. I was part of the VA diabetes trial. We saw a tendency towards harm. Yes, you get some retinopathy and kidney benefits, but not for cardiovascular disease. And I've shown this slide also many times before. I like it. Miles Fisher is a diabetologist from Glasgow. He said diabetes actually is premature cardiovascular death. You have chronic hyperglycemia and may be associated with blindness and renal failure. And the crux of diabetes, of course, is premature cardiovascular death. But we focus on treating glucose, bringing it down. I told you in the ACCORD study, tight glycemic control was bad. Not bad, I mean, it improved microvascular, but CVD harm. And then after the rosiglitazone episode, the FDA came and look at it. This is guidance. It is not mandate. But they said any drug diabetes going forward, this is the only thing for blood pressure, cholesterol, other diseases, they don't say it. You have to show cardiovascular safety. And that is where we got our CVOTs. Let me give you another interesting point. Where did the word MACE come from? MACE. I don't have the slide for it. MACE stands for Major Adverse Cardiovascular Event. The first use of the term is in 1993 in the American Journal of Medicine. It was coined to capture events taking place during stenting. At that time, stents were being put, and when people got stents, they had a stroke or they got an MI. And in the original article, it is major, adverse cardiovascular events. At this time, the FDA came, they didn't know what to do, take MACE and gave it. And you know what happened after that? We had the serendipitous finding of heart failure and kidney things. What did we learn from the CVOTs? I think DPP-4 inhibitors, without a doubt, really no MACE benefits, some benefits on albuminuria, no effects on going to ESRD, some molecules, maybe an increase in heart failure. GLP-1 till today, in the powered trials, MACE benefits, no CHF benefits so far. It is coming. It may be coming. And the real benefits so far, albuminuria, no hard outcomes on progression to kidney disease. Dr. Tuttle showed you those slides. Those are secondary outcomes from the award 7, the dulaglutide side, but not proven. We have to wait for the thing. But SGLT2 inhibitors, they have MACE benefits, they have CHF benefits. Now, granted, the MACE benefit is not so much for stroke and heart attack, but it's still there if you aggregate it all together. Renal benefits include progression to kidney disease. As I told you, albuminuria is a marker, surrogate marker, and albuminuria is a better predictor of cardiovascular disease. And we talked about that in the previous sessions. It doesn't predict renal failure that much. Why is heart failure so important? Remember, EMPA-REG got the MACE outcome. Canvas got the MACE outcome. Declare to me was a low-risk population. Everybody did not have heart disease, only about 60%. So before they broke the blind, before the analysis, they went to the FDA and said, we are going to have 2 co-primary endpoints. That's when the heart failure came in. They sensed that something else is going on here. Anyway, heart failure, I think this is my good friend David Bell. This he wrote almost 20 years ago. He said it's frequent, forgotten, fatal complication, highly prevalent in some populations, 1 in 5 patients, and it is hidden. You don't even find it. If you do it, HFrEF we pick up because people get, this thing. HFpEF early stages, nobody picks up. Ejection fraction is good, go away. HFpEF was only described in the latter part of the last century, 1990s. Now HFpEF is a huge deal. Anyway, anybody who gets diabetes and heart failure, the prognosis in a Medicaid database, median survival 4 years, about 10 to 20% mortality. That's seen in our placebo group in the heart failure studies. It's not a good disease to have if you get heart failure over there. And of course, I showed this before. The heart and the kidney talk to each other. Remember, the heart beats 1 lakh times a day. It's tens of thousands of liters, and 1/4 of it goes to them. They both have to talk to each other. If the heart doesn't pump, the kidney's in trouble. If the kidney doesn't do its job, the fluid backs up, that's guy in trouble. And I showed this before. Patients with CKD more likely to die of heart disease, heart failure. So this is something I didn't show in my previous slide. Are there any differences in the cardiorenal outcomes between SGLT2 inhibitors and GLP-1? Now, nobody will ever do this study. This is an older meta-analysis from Zelnicka. But basically, I think it's still true till today. In trials to date, GLP-1 and SGLT2 inhibitors reduce atherosclerotic MACE to a similar degree if you have established atherosclerotic cardiovascular disease. I am not able to show you the slides for want of time, except in the Vertis study. But SGLT2 inhibitors so far, marked effect preventing hospitalization for heart failure, progression to kidney disease. Across the board, all the compounds do it over there. In my opinion, so far, the GLP-1 receptor agonist benefits are mainly due to anti-atherosclerotic effects on the pipe, the epicardial artery. Of course, there is improvements in A1C, very good improvements in A1C, good weight loss, some blood pressure effects, some lipid benefits. And there are GLP-1 receptors on the vessels. It's got anti-inflammatory effects, endothelial effects. But so far, benefits are shown only for atherosclerotic disease, not so much for heart failure or kidney failure. Not so far, not as a primary outcome. I think it is coming because of the other effects. SGLT2 is mostly on the pump. It doesn't have much atherosclerotic benefits on stroke and heart. Why? Because its benefits on that is because, hey, it improves heart function, so you're pumping better. Remember, heart fills during diastole. So if your heart function is better, you're filling your heart better. And you remember, in patients with HFpEF, they barely get the ventricle is thick. It is squeezing the heart over there, and they barely can get any heart flow. But it has got some effects due to blood pressure, lipids, and all. And this, in some earlier studies, the GLP-1 receptor agonists actually had detrimental effects on the pump. Maybe it was due to an increase in heart rate. And these two studies are there, the FIGHT study and the LIFE study. There was actually an increase in heart failure, but not seen in the large CVOT so far. And perhaps now some IV studies with exenatide showed benefit, but so far we really don't have dedicated study for heart failure. So meta-analysis of all SGLT2 inhibitors, time to first heart failure, I think even if you include Vertis over there, it is all in the right direction, about a 32% reduction over there. I don't have to tell you the studies, these have been discussed before. We saw it as a primary outcome in dapagliflozin, DAPA heart failure study. People with an ejection fraction 31, it reduced worsening heart failure 30%, CV death, all-cause mortality 17%. Didn't matter if you had diabetes over there, and also reduced progression to diabetes by 32%. Of course, we had Emperor reduced heart failure study, similar outcomes, except CV mortality was not there. Emperor preserved was just presented, and the mean of these people had an EGFR more than 40%. Again, effects on heart failure without a doubt. And in my previous session, I discussed the renal outcomes, how it slows the EGFR progression. What about kidney failure? The dedicated study, I discussed this before, so I'll just repeat it. in 4,400 patients. Again, it's worth repeating. If you have albuminuric CKD, mean eGFR 56, primary outcome, I've told you this, 30%, renal specific outcomes by 34%, MACE and heart failure. And study stopped early by the DSMB. Dapagliflozin, the big difference, about a third of patients, no diabetes over there. Again, really powerful effects. And Dr. Tuttle also pointed out, all-cause mortality 31%, on top of ACE, ARBs, anything else, statins and over there. Again, independent of diabetes, stopped early. But what effect does this have on our guidelines? So this is the I have to update it a little bit more, but it hasn't changed much. I think this is the most important thing. Avoid clinical inertia. And I know Professor Kamlesh Kunti calls therapeutic inertia, where we have to keep following our patients. Metformin still first line, it has not been a thing. And just for your information, metformin's cardiovascular benefits have never been conclusively proven. In a sub-study of UKPDS 341 patients, MI was there. Yes, they did the legacy effect and all that. Actually, we in the VA, we're doing a study called the VA Impact Study. We obviously cannot do a placebo-controlled trial in type 2 diabetes because metformin is standard of care. But we are taking people with pre-diabetes who've already had a heart event, MI or stroke, and they will get metformin or placebo. But then the guidelines say, if you have established atherosclerotic disease, CKD, heart failure, consider independent of the baseline A1C. So if your A1C is already 6.8 on metformin, please, if there's ASCVD, then preferably GLP-1 or risk for this, or an SGLT2 inhibitor, or if it is heart failure, CKD, they say preferably SGLT2, if not tolerated. That's the guidelines so far. If you want to avoid hypoglycemia, of course, avoid SUs or insulin. Weight loss, then don't use SUs, insulin, or TZDs. And of course, if cost is an issue, they're out of luck, SUs or TZDs. So this was in reference to the DAPA heart failure trial. They said SGLT2 inhibitors are evolving into a cardioprotective therapy that incidentally lowers blood glucose. It was initially developed for treatment of diabetes, but now people with heart and kidney disease have at least as much to gain. So that's a real paradigm shift in diabetes. So again, I showed this before, a little bit of a twist. We've come a long way in 5,000 years from Hesira to Charaka. I misspoke before. He's 200 BC. It is the Charaka Samhita. Then, of course, we had the meat diet with Rollo. We had the oat cure with Frederick Allen. We had the keto diet with Jocelyn. We had insulin. And of course, I've shown you this before. SGLT2 inhibitors really turned symptoms into therapy, and they have taught me more about diabetes than I've learned in the last 20 years. I showed this before. They truly are a man for all seasons, like James Bond, like, the pump, the pipe, the filter, everything is covered, and also perhaps diabetes. And I think they have introduced a paradigm shift, as I said, not only in diabetes, but also in the management of diabetes and heart failure. Again, I use this term a lot. It's not my term. It literally is sweet success for the diabetic heart and the kidney. Let me finish. I have 2 minutes left. I use this a lot. I love Kalidasa's Malavika Agnimitran. And those of you, you should read Meghadutam also by him. Beautiful books over there. And he's a widely regarded poet. Again, we don't know when he lived. Probably 400, 500 in the court of King Samudragupta. And he said, do not accept anything as good just because it is old. So we are questioning metformin. Does it really have cardiovascular benefits in the VA impact study? He said, don't reject anything as useless just because it is new. SGLT2, everybody said, it's going to destroy your kidney. Yeah, there are side effects. I'm not saying no. And he said, the wise weigh the substance for themselves and decide for themselves. It is the unwise who are led by the opinion of others. And I think with conferences like this, you get the latest and the greatest from all the best people all over the world. And thank you so much for your